Good evening, everybody, and welcome. It is a pleasure to be here. I was here this morning, but it's still a pleasure to be here teaching and talking and learning from colleagues and friends. So, next slide. I'd like to thank Merck for sponsoring this evening. I am not receiving an honorarium for this evening. I'm just sponsored for food and to make sure that people showed up and are learning today. So this will hopefully be, as you understand, a talk that talks about risk and not one particular drug. That's the next slide. That's the way I like to talk. Slide. Okay. So I'd like to go over how we assess and manage the patient who's at risk for coronary disease. And in fact, the question in the question period just before the talk, I'm trying to allude to these are questions that we all have in our daily practice. I want to review recent lipid-lowering trials that look at reducing risk. And there have been several breaking trials in the last month that have changed my practice. So we're going to review some clinical trials, and then we're going to discuss some future research that addresses this concept of residual risk. What is residual risk? Next slide. Well, residual risk, say that 10 times fast, is the risk left over after we've done everything we can do. And that's the concept, and that's the buzzword in preventive cardiology. And this case will, to some degree, go over residual risk, but I took a case out of your common family practice day, and they'll take another case out of my busy cardiac day that shows what residual risk is like. So Mrs. Rain, she's a 61-year-old retired teacher. She has some borderline hypertension for which you're treating her with hydrochlorothiazide. She has fibromyalgia, and yes, I'm happy to see your patients, but when she comes in with her pains, they're less likely to be her heart with the fibromyalgia. Her brother did have angioplasty at 54. She's still smoking, despite attempts at quitting. Now, the one thing I've tried and teach people over the years is that for a well woman, an annual health exam includes a cardiac risk assessment. We tweak it into our minds that way, then doing a Framingham risk score, doing the appropriate testing at midlife and even before, it becomes routine. And I think women need to be aware of that. And, you know, she's feeling well. She has no voice complaint. You examine her. Her heart rate's 72. Her blood pressure is 140 over 70. Her waist is a little larger at 88. But her exam's otherwise unremarkable, including a full vascular cardiovascular exam. We don't detect any endorphin damage when you look at her with her hypertension. And her creatinine is normal, no proteinuria. Did an ECG because she's got some hypertension. There's no LVH on the ECG. And there's no features of metabolic syndrome, truly. So the question then arises, next slide, should you bother screening her for cholesterol levels? And I'm seeing some nods in the audience that say yes. Well, the first answer would be yes, because she has one risk factor for coronary heart disease. She has hypertension, even if it's just mild. When there's one risk factor, we need to go looking for others. She does smoke as well. However, if she walked into your office without the hypertension and had quit smoking, does she need a cholesterol screen? In fact, next slide, the CCS guidelines do recommend that for men over age 40 and women over age 50 or who are postmenopausal, we should have their cholesterol screened. That does not mean once every 3 months. It may not even mean once every year. It actually is once every 3 years in somebody who's stable. Now, in this case, my mutual patient of ours, she actually has risk factors for coronary heart disease, and we probably recommend screening her Framingham risk score if in fact, it changes our management every year at an annual health exam. And we should consider early screening when we have a family history of premature coronary disease, as she had with her brother, when there are multiple CV risk factors, or you have a history of severe cholesterol on siblings or parents, even if they have not had coronary heart disease. Next slide. So we draw her blood, and her fasting sugar is normal. Her total cholesterol 6.2. Her HDL is 1.22. Triglycerides 1.54, and her LDL is 3.4. I'm going to ask everyone in the room, not because I'm sitting here in front of you in a Toronto Heart Center saying we're talking about risk, that in your gut, this person who walks into your office who's feeling well with this lipid profile, is her risk, you think, going to be low on Framingham, moderate on Framingham, or high on Framingham? Can I have a show of hands? Just I guess low, moderate, high. Okay, so you're not alone. There is some equipoise in the audience. When I give the same scenario to cardiologists at our Canadian cardiac meetings, we tend to underestimate risk. In fact, next slide, it goes to what her cholesterol doesn't need to be treated, right? That depends on her risk. So, when a patient asks me what's the normal cholesterol, the honest answer is it depends. It depends on your risk. And I'm going to treat you if you've had your angioplasty or bypass surgery in the last year or 10 years, regardless of your cholesterol level. And I may treat you if you have multiple risk factors, depending on your future risk. So next slide. So should she be treated? So this is the point. We tend to underestimate risk in women and in older women, and we tend to overestimate risk in younger people. So at first glance, you think her risk might be relatively low. This is a little typo here. I'm sorry, no family history. She has a family history, no metabolic syndrome. But in fact, if you look at her Framingham risk score, and we're going to calculate it together, she calculates out to be intermediate, but then you have to double her risk for her family history, okay? And the recommendation, okay, when her LDL was above 3.5, even if she was moderate risk, some of you said moderate, she's actually at high risk for future cardiac events in the next 10 years. But staring at her in our office, as we were trained in medical school, our red warning bulb does not go off that she's at high risk. She is, though. And so we should be starting treatment with a statin, trying to get her LDL less than 2 or reduced by 50%. In the question period, I'll talk to you about this or versus and in terms of lipid lowering, what is recommended, and what I do in real life depending on the patient. We're certainly going to initiate some lifestyle measures if we can and work on smoking cessation. And this first treatment is a statin. Next slide. So this is how we got to her risk scoring system. She's 60. This is the new point system based on a modified Framingham risk in the last 3 years by Canadian Cardiovascular Society lipid guidelines. If you're using old papers, which I suspect you're not, because I'm preaching the converted when you come out on a night to a CME for people who are in the know, that this risk scoring system actually is a composite scoring system of both heart attack and stroke, cardiovascular. So your points will be similar to an old Framingham scoring system, but your risk is higher. So someone whom you calculated a Framingham risk score on 3 or 4 or 5 years ago, calculate it again because you might be off a little. We were underestimating risk, and we're being appropriately diagnostic at this point. So if your risk is, she's 60 to 60, 64, I often say this, even the best plastic surgeon can't change the inside of her blood vessels and coronary arteries. She gets 9 points. And with Framingham, although this is a criticism, I actually think it is something that is a fact that age drives risk in cardiovascular medicine. So the 70-year-old in your office is at much higher risk than the 40-year-old, all else being equal. I've had over the years very good family doctors who I work with who have told patients, well, my total cholesterol is high, but my good cholesterol is high, and that should protect me. The truth is HDL does not protect as much as LDL deters. And if you just look at Framingham, she doesn't have any points for her HDL to score, but her total cholesterol does give her points. The most one can take off for a high cholesterol is 2 points, and the most one can have for a bad cholesterol of total cholesterol in total is 5. So HDL does not negate LDL. And the other thing is that I put a purple circle around here because when I went to medical school and when you went to medical school, most of us in the room, a systolic pressure of 140 was not considered hypertension. But it is treated hypertension in this individual, and that confers tremendous risk to her. And she actually gets 5 points on Framingham for having a systolic pressure of 140 because it was 160 before the hydrochlorothiazide. That increases her cardiovascular risk. Now, she smokes. Now, you're going to say that's not a dichotomous value. She either smokes or doesn't, a half a pack, quarter of a pack. I think there's room for discussion when you use Framingham as a stepping point for your patient. But the duration of that risk factor is as important as the level of the risk factor. So if she's been smoking a quarter of a pack or a half a pack a day for 20 years, her risk is significant. And that's why she gets 3 on Framingham. Again, diabetes is a yes or no on the new Framingham. It no longer is considered a risk equivalent. We used to say, well, if you have coronary disease, or if you've had a TIA, or if you have peripheral arterial disease, if you have vascular disease, you're high risk. Absolutely. We used to say if you have diabetes, you're also high risk. And while that's so in most of our patients, it's not so in all of our patients. And the new Framingham risk score has taken this into account. I would suggest to you the reason for this is if you have a young type 1 diabetic in your practice who's well controlled, that individual's risk in the first 5 years of their life, 5 years of their history of diabetes, or even under 10 years, is not the same risk as a type 2 diabetic who has insulin resistance. So you have to make your own decision as to how many points on Framingham this individual has. If it's a person walking into your office who hasn't seen a doctor in 5 years and you know has had poorly controlled type 2 diabetes, the risk might not be just the 3 points on Framingham. It may not be a risk equivalent. You have to individualize. So I think that's where our new guidelines are going about assessing risk. Next slide. Next slide, please. Next slide, risk. Okay, so we've calculated her points, and actually her points come out to 21, and we haven't talked about family history. But because of her family history, we actually double the risk. You don't double the points, you double the risk. So if her risk for some reason was moderate, and she had a 13% risk in the next 10 years of a heart attack or stroke, her risk is then 26%. That's what Framingham teaches us. So it's very important that we take that into account. Next slide. So Framingham is a good stepping stone. We can go beyond Framingham. We have to be aware that Framingham doesn't apply to all ethnic groups. I sit down with my patients when they're sent on for a risk assessment and says, this applies to a group of white, middle-class people out of Framingham, Massachusetts. It probably applies to you genetically, or you know what? You're of South Asian background, your risk is probably a little higher. And we need to individualize that risk to some degree. There is a lot of emphasis on age. Some people think too much, but I think epidemiologically it's probably accurate. But it does tend to underestimate risk in young and overestimate risk in elderly. It doesn't account for family history, but our Canadian guidelines say that you should double it. It doesn't always account for the insulin-resistant patient, and certainly the patients with renal impairment, who we know are actually at very high risk in the future. And that's a very big signal in cardiology, right? If you have impaired renal function, your risk is higher than the average person, all else being equal, with normal kidney function. And it also doesn't take into account lifetime. You know, I have a young fellow, a cardiologist working with me from Winnipeg for the year, and he's going to go back and run a prevention program in Winnipeg. And I said, we talk about prevention, we talk about risk, but even our guidelines, certainly our trials, they're 4 years at a time. Our guidelines suggest and talk about 10-year risk, but if it were me, I'd like to know my lifetime. Hopefully 60 will be the new 50 in 20 years, right? So we want to make sure that we're taking care of our patients lifelong. And that may not mean lifelong medication, but it does mean that we have to rethink how we approach risk factor assessment and then risk reduction strategy. Next slide. So without going into a lot of detail, we've mentioned there are patients who are at higher risk. Those with known vascular disease, those even with silent vascular disease. In fact, if you pick up somebody with a BRUI, written Canadian guidelines on vascular disease, a reduced ABI or a femoral BRUI for sure puts you at significantly increased cardiovascular risk. Carotid atherosclerosis that's picked up coincidentally, those patients are also at increased. Having said that, are they all high on Framingham? I treat them as if they're high on Framingham and make sure they're on a statin. Without having presentation of disease, they're probably not quite as high as the patient who's already had the TIA, but I still put them in the moderate high group, and certainly our guidelines would like us to think about them as these patients as high risk. And then certainly we did talk about this without looking at the slide, that most patients with type 2 diabetes certainly are at higher risk, and that's a different type of diabetes, type 1 diabetes, and chronic kidney disease. So I'd like to go on to the next slide. Okay, and remind you that our Canadian guidelines, which are not so new anymore as we enter 2012, basically say go big or go home. If you're going to treat appropriately. Now, I am not here to support any one drug. I'm not here to support any pharmaceutical industry. But at the end of the day, patients on Pravachol 10 are not meeting guidelines, even if you think they're where they need to be. Our guidelines should say all patients, if once we decide that we're treating, okay, she was high risk, her LDL was above 2, we're going to treat it. We're going to treat it to less than 2 or 50% LDL lowering, but try and go big or go home. We should try and lower LDL by at least 50% if you decide to treat, and that's regardless of your risk category. I'm going to take questions after because we're being audio taped, but if you want, write it down because I will be happy to take that question. And that's something that we need to think about and self-audit our practices because we have patients for many years doing reasonably well on several drugs, but really in clinical practice, there are patients who are intolerant, but really in reality, doses of simvastatin 40 and greater, atorvastatin 10 to 20 or greater, and rosuvastatin 10 or above really are the doses that we should be using in terms of potency of statin. And when we're not at the right dose or meeting the right target, then we can add an additional drug, and we'll talk about the evidence for that with a drug such as ezetimibe. Next slide. So that's a patient who's at risk, and she has residual risk because there's risk hanging around. But the residual risk we talk about in the literature is this patient I'm going to present to you. This is Mrs. W. This is a patient that I've been following for almost 9 years now. She's 61. She's South Asian. She's married with 2 kids. She's a lovely woman. I built a lovely relationship with her. She's had type 2 diabetes for 25 years. She has been on insulin for 4, and she has SLE, which is stable and has not required a lot of prednisone. In fact, her rheumatologist sent her on to me many years ago. Her first MI was 10 years ago. At that time, she had a coronary angiogram, and she had 3 vessel disease that was not amenable to surgery in the setting of normal ventricular function. And we can talk about that afterwards, but the treatment decision, which was appropriate at the time, was to treat her with medical therapy. She was put at that time, and she has been on for many years, Lipitor 80, Ezetrol or ezetimibe 10, enteric-coated aspirin, Plavix 75, Ramipril 10 BID for blood pressure control, losartan for blood pressure control, bisoprolol 10, insulin, and metformin. Okay? Her hemoglobin A1C is not that bad, 0.68. Her LDL is 1.8. Her HDL is 1. Her blood pressure is reasonably controlled at 135/75, and her pulse is nice and low. Despite that, she has had recurrent TIAs and unstable angina and 3 admissions to hospital in the last year, all with positive troponins. The last time we said we're going to try and do an angioplasty to her circumflex artery to help her with some symptoms, but it's not going to reduce her future risk of event. She has a problem with her vasculature. And in this patient, what do we do next? What can we do? That concept is the concept of residual risk. What's left over? What can we do to prevent further issues in cardiology? And what I'm going to go through with you in the next little while has to do with some very new research that will come down and trickle down into family practice, I think, in the next few years, and some studies that have shown to be helping us guide our patients through this area of what to do next. How can we manage residual risk? Next slide. So that's the question. How can we manage our future risk? What can we do to reduce the residual cardiac risk? Next slide. Well, we know residual risk is not unique to her. And in fact, if we look at several studies, and I'm taking some statin studies, we've got Miracle, Improve It, the studies don't matter. What the point is that despite being on high-dose statins, you still have an event rate out after an MI for death and non-fatal MI or recurrent angina. So she's not alone. So drugs help reduce risk, but there's still risk left over. There is still residual risk. The same holds true if you look at another trial, looking at the Prove It trial. So patients are still at risk because that yellow line still can approach 20% after MI. We're getting better at managing that with interventions and drugs, but residual risk is a problem. Next slide. So what can we do? Well, what about anti-platelet therapy? Well, as you know, in Ontario and most places in the world, in most patients after an MI, there is a concept of dual antiplatelet therapy, both clopidogrel and aspirin. And that's because a trial such as the CURE trial showed lower event rates on the dual antiplatelet therapy compared to that was aspirin alone. These patients who had placebo, sorry, I'm using my mouse to realize it's not, but patients who used placebo really on aspirin. But you can see that even with dual antiplatelet therapy, there is residual risk. At 12 months, there's still a 10% event rate. So even though we're good at it and we're getting better at it, we still have risk left over. So she's on dual antiplatelet therapy. Next slide. Well, what about her LDL? How low should we go? What's the benefit of ezetimibe? I've given you a patient who's on maximal medical therapy, but the question could have just as easily been that her LDL was 1.8 on Lipitor 80. What else do we need to do? So that's a question that we need to address, and there's some good data out there. Next slide. Well, how low should we go with LDL, I think, is an important question. I'm going to show you this slide reflects the TNT trial, which is an ambulatory trial in patients randomized with coronary disease to atorvastatin 10 versus atorvastatin 80, no placebo. This is a trial that changed my practice. This trial is now 6, 7 years old. There are still people out there reducing statin doses because people are nervous when patients are feeling well and there's no evidence of transaminitis or elevation in CK. And let me remind you, although I have to admit, I thought this was going to be a negative trial. It changed my practice because the patients who were randomized in the green to atorvastatin 80 had lower event rates than those on atorvastatin 10. Okay? So the higher dose statin, the more potent statin at lowering LDL compared to another statin, still won at the end of the day at reducing event rates and helping reduce residual risk. That's why many patients leaving hospital after acute coronary syndrome are put on relatively high dose statin. This is a trial, if you look at it, that has followed over 6 years and is an ambulatory trial. There is nowhere in this trial that there's a suggestion, oh, 6 months out after the MI, year out after, let's back off. People read things, are worried. I think an intelligent discussion, and certainly when patients are on high dose statins, CK and LFT assessment at least every year, if you're concerned every 6 months, is reasonable. But these patients can have their residual risk managed by keeping them on high dose statins. And that's the TNT trial. Next slide. In fact, if we look at LDL lowering, there have been 14 randomized trials of almost 100,000 patients to date looking at LDL lowering. And what we can see that is for every 1 millimole of LDL lowering, we can reduce all-cause mortality, coronary mortality, reduction in MIs, reduction in revascularization, in stroke, non-fatal stroke, and there's been no suggestion or signal in the literature that there's non-vascular mortality or cancers are increasing. You know, when I went to medical school, people were worried. You take the LDL out of your brain, you need to think. You take cholesterol out of your brain, you're going to be anxious and jump off a bridge. That has not shown to be the case. There was a concern. The younger doctors in the audience are laughing, but there was a true concern about having neuropsychiatric side effects of these drugs. Not been proven at all. And in fact, no signal in the literature whatsoever now that these drugs cause cancer. So at the end of the day, lowering LDL is important. And I remind people of that because we have this medical inertia. Our patients stop drugs. They're feeling well. Does it really make a difference? They've been on the Pravachol for so many years. There is some data that suggests that going lower is better. And being aggressive in that regard will help manage residual. Next slide. Okay. Again, that's why the Canadian guidelines say go big or go home. Because when you lower LDL by a significant amount, you're going to have a clinical impact on your patient. Next slide. So what about ezetimibe? Well, there's several trials going on, and the actual details of the trials are not that important. Suffice it to say that we're going to have a trial that will report out in the next 2 years, which I'm a part of, St. Michael's is a part of. I have about 20 patients in this trial. We may share patients in this trial, looking at patients who've had an acute coronary syndrome who are randomized, 10,000 patients all over the world, to receive either simvastatin in doses of 40 to 80, so 40 to 60% LDL lowering, versus simvastatin 40 to 80 plus ezetimibe, which gives you another almost 25% LDL lowering on top of it. So it will show whether this is an effective combination, certainly if it's a safe combination, and how low should we go. So we will have some of this data coming out in clinical trial evidence in the next few years. Until then, in the absence of data, there seems to be enough epidemiologic and trial data that says the lower the LDL, the better, but then we pick the right patient. Mrs. W, who I showed you, who's having TIAs and unstable angina despite having a perfect lipid profile, is the person I would add the ezetimibe on top of the atorvastatin 80. The first patient, Mrs. Rain, who walks into your office, right, who has high risk based on multiple risk factors, you're probably not going to use dual therapy for lipid lowering because they're high risk based on different criteria. And in fact, within the spectrum of the high risk patient, the first patient is a lower risk patient. He has multiple risk factors, but doesn't yet have heart disease, than the patient with severe vascular disease recurrent event. So there's a spectrum of risk even in our high risk group. And I think that's something to think about. The other warning sign for you in your clinical practice is you have a long-standing diabetic with remote revascularization. So the patient who had bypass surgery 10 years ago, actually whether or not they're diabetic, we want to keep those bypasses open, and the patient who has diabetes who's had any event, those patients tend to be higher risk and warrant further aggressive interventions without the absence of evidence, in my opinion, right now. So LDL cholesterol is important. Next slide. What about HDL cholesterol? Well, the expectation that is an observational study, a milligram per deciliter increase in HDL is associated with a 2% reduction in coronary disease in men and a 3% reduction in women. So that sounds good. You know, HDL is a good thing. The issue is that on top of contemporary statin therapy, how much HDL raising is effective. Next slide. Now, HDL is a very complex. HDL is a complex system. It's a lipoprotein, but it's not just one lipoprotein. There are various subtypes of HDL, and certain subtypes of HDL are effective at helping certain aspects of vascular health, and other subtypes of HDL others. So this slide is to suggest, to simplify it, that HDL actually just affects vascular tone, inflammation, hemostasis, and the integrity of the endothelium. And at the end of the day, HDL is supposed to wave a flag, and it's the big protector of the endothelium. But it's not just one molecule. It's not so simple. In fact, I was just at a meeting for our Canadian Cardiovascular Society, and Rob Hegley, who's an expert from London, Ontario, used to be at St. Michael's Hospital talking about HDL, answered a question from saying, you know, HDL is not one entity. It's a complex system, and it's a complex question as we go forward to raise the question, will drugs that affect HDL work? Next slide. So we have currently various therapies available to us to raise HDL. We have fibrates, which we have trials such as the field trial that on top of contemporary statin therapy, really very little benefit. I only use fibrates in my practice when your triglycerides are over 10. There are endocrinologists out there who might do it differently, but if you're at risk of pancreatitis, fibrates are useful. Otherwise, we don't have a lot of data that they help in terms of reducing residual risk. We have niacin. I'm going to show you some very exciting news. First trial in many, many years on niacin, because niacin could raise HDL by up to 40%. And then we have various investigational therapies. I put these up here not for you to memorize their names and not to go into detail, but to tell you that HDL is the new buzzword, the new sexy word. In the next little while, you're going to see a lot about HDL, I think, in the prevention world in the next 5 years. We're starting to already. Next slide. So hot off the presses, less than 1 month ago, one of the largest niacin trials out there was presented at the American Heart Association meeting in November. And this was using niacin in patients with low HDL receiving intensive statin therapy. They were my patients. They were your patients. In fact, I had 40 to 50 patients at our site in this trial, funded by the NHLBI, and it was a large study looking at niacin to raise HDL. Next slide. To get into the study, you had to be over 45 years of age and have disease. So coronary disease, cerebrovascular disease, or peripheral arterial disease. And you had to have a dyslipidemia. They weren't taking all comers. So you had to have normalish LDL and low levels of HDL. Next slide. So what did we find with the study? We found that niacin raises HDL. Good. But we're talking about a surrogate marker. Remember that. It's not a hard endpoint. Niacin raises HDL. That's what we thought it would do. Compared, and combination therapy means statin plus niacin versus just statin alone. Next slide. It's actually, before you go to the next slide, it is actually interesting to note that patients who were receiving the statins had HDLs raised as well. Now, why that is unclear. It may have to do with a selection bias or a healthy volunteer bias if you enter a clinical trial. So if you're going to go into a clinical trial, you get a little more TLC from the nurse coordinator and from the study person, and you may be just more motivated, an individual, to enter a clinical trial. But HDL was raised in both arms. Next slide. And LDL fell. In fact, more so with the niacin, as we would expect. I won't go into details, but you expect the LDL to fall with the niacin and the statin. So this looks good so far. Next slide, please. Put up with the flushing. The problem is that there was no difference at the end of the day in terms of the primary endpoint of hard cardiovascular outcomes, whether you got the niacin or not. And this is a cautionary tale for everyone. So next slide, if you're more of a visual person. Sorry, slide. Yeah. that those lines overlap. It did not matter whether you received niacin, statin, or the statin alone. Your endpoints were the same, even though your lipid profile looked better. So I'm not trying to diss any of my colleagues who are focused on numbers, such as endocrinologists who I'm friends with. But remember that numbers are important, but they don't tell you the whole answer. You need to have the hard endpoint clinical trial data. And I think with this trial, and niacin was very promising. In fact, it was the one thing out there we said would be helpful. If you have patients on niacin now who are tolerating it, you can tell them, I think, they have coronary heart disease or established disease, probably to stop if they're on statin. Now, it's different if the patient didn't tolerate a statin in your practice, because these were patients in comparison to intensive statins compared to statin plus niacin alone. But we now have data on niacin showing it's not helpful. Next slide. Next group of drugs that you're going to see more and more about is a drug called a CETP inhibitor. Won't talk a lot about details, but they are drugs that raise HDL. It's been proposed as a mechanism to raise HDL. However, the therapeutic potential of the small molecule inhibitors is being explored. It's not proven yet. There was a CETP inhibitor on the market that was pulled in the clinical trial phase because it actually caused more harm than good. It was a drug that affected the renin-angiotensin system too as well. Blood pressure went up, potassiums went up, and the trial was stopped because it was causing harm. All the CETP inhibitors that are being investigated now have had a much higher bar to jump over or go over before going into clinical trials from the FDA and Health Canada. And next slide, we're actually looking at this. So there's several trials out there. There's the dal-OUTCOMES study, which is ongoing right now. This is patients who have had an MI who are actually being randomized to this drug to raise HDL or a placebo on top of contemporary therapy. And I will tell you that we're starting very soon. So you have patients with established disease who are keen on raising their HDL, give me a call for a clinical trial looking at patients with chronic stable CAD and this new drug. Of course, the patient would have a 50-50 chance of getting this access to this new drug that we don't know is effective or not, but we do know does raise HDL. The fact that we're doing a large clinical trial program with this drug would make me suggest certainly it's safe, and there's a lot of investment in it. Now, whether at the end of the day it makes a difference will be why we're doing this trial. So dal-OUTCOMES 2, we're actually submitting to the Research Ethics Board today to get going in January. Next slide. So residual risk. We talked about LDL, adding a drug such as ezetimibe. We've talked about HDL, trying to raise it. Niacin seems to not have worked. What about platelet function? Can we do anything else than the clopidogrel and the aspirin? Well, next slide. So it turns out, and this is for everyone to memorize in detail, that the platelet receptors are very, very complex parts of our body. And in fact, there are so many receptors on there that when I hear an expert talk, I hear it and then it goes out of my brain because that's not my area of expertise. You just need to know it's complex and there's lots of room for potential investigation and treatment to see if we can reduce residual risk. Next slide. So we actually have something called a direct thrombin inhibitor that's been in clinical trials that we're going to get some data on. It's kind of a neat compound that's been developed because it actually is supposedly reducing risk at the platelet level but not causing increased bleeding. Let me tell you, when something is built to be too good to be true, it usually is. I don't know yet. We'll find out. It was kind of interesting because some of the preclinical data did not show an increase in bleeding or clotting times, actually. And it found this compound came from the tropical zones of eastern Malaysia, New Guinea, Australia, and the Solomon Islands, where people have been using traditional healing for many, many years. So it's kind of a neat historical background as to drug development, finding an herb out there that may be working. Next slide. In fact, there's a huge clinical trial program with these drugs. What you need to know is that there are a lot of patients, 29,500 patients, 30,000 patients in these studies. And we have just completed a trial. We've had 50 patients at St. Michael's Hospital in this TIMI 50 trial looking at this new compound that should help affect the platelet function compared to placebo on top of normal therapy. So all of these trials are trying to minimize residual risk on top of contemporary therapy. And we're trying to see whether this reduces stroke or heart attack. Next slide. And it's going to become, so this is the trial program we're on. So next slide. So In fact, the results are coming soon. I, just to be, again, hot off the presses, had an email on November 22nd saying, prepare for final database lock, a key database reconciliation step. So the data, the study is over. Patients are now stopping medications, and we're going to have that information about how we can manage residual risk, I think, in the next year. So stay tuned. We'll come back and talk to you about that. Next slide. So what about inflammation? Well, we think that inflammation is involved in the coronary arteries when people have a heart attack in an acute event, but we haven't figured it out right now of how we can reduce risk by managing inflammation. In fact, we know with certain anti-inflammatories, there's a signal in the literature that it may be actually harmful, putting somebody on a coxib or an NSAID. So that hasn't been shown to be helpful. Next slide. But we're doing trials with newer compounds. Don't need to know the details, but some really interesting studies going out there, and we're actually actively doing this at St. Michael's, looking at this anti-inflammatory compound that works out very early in the inflammatory chain in comparison to placebo on top of a statin. And this is a 6-month trial, and we'll have data on inflammation actually and residual risk in the next year or so. The other next slide, thank you. So who is at high risk? So we've talked a lot about residual risk. I've given you 2 patients who are at high risk. I want to remind you that, next slide, the animation, thank you, that it would be nice if we had a signal, if someone walked into our office that says, you are in a high risk group, okay? Probably the whole human race is in a high risk group, but we need to sort out risk in our office. Next slide. Certainly this patient is at risk of falling, and I wouldn't do mountain climbing. And certainly this patient is at risk of falling. We're not falling off the dialysis table, but falling in a more ominous way, metaphorically, because remember, take-home message, patients with renal disease are at high risk. And you don't have to be on dialysis yet to be high risk. And in fact, there's been a lot of question out there as to whether lowering cholesterol helps people with renal disease. And sometimes the thought was that if you're already on the dialysis machine, it's not that you shouldn't be on the statin, it's that the disease is so complex and there's so many things that affect risk that it may not be of help. It may be too little too late. Okay? So we want to catch the patients before they go on dialysis. And in fact, next slide, there was a recent study, again, I'm showing you recent data, that has come out looking at the results of heart and renal protection in patients who are pre-dialysis and dialysis. I will caution you, I'm not sure this has been fully published, but we'll go over the details. These were patients who had chronic kidney disease, okay? And so, over creatinines of over 150. They could be on dialysis, but they didn't have to be. They were over 40, and they didn't have heart disease. And in fact, the question as to whether you should put them on a statin or not was uncertain. And in fact, that's probably the case for many of our patients up until recently. And this is a trial, next slide, sorry, that took patients basically and randomized them, a little more complex, but to make a long story short, about 4,600 patients went in to receive ezetimibe and simvastatin versus placebo. That's placebo, because we felt the damage may have been done in these patients and we didn't know if it would be helpful. These patients were followed for 5 years. Next slide. And we saw who these patients were. They were 2/3 men. They were 62 years of age. Blood pressure was kind of average. And there were 6,200 patients, if you look at this lower slide, that were not on dialysis. And that's the population that you see and I see with impaired renal function, chronic kidney disease, who do not need yet dialysis, is reducing LDL, of course. Next slide. Most had albuminuria. Next slide. So what we found, next, with a lot of animation, so you just look at the animation, please. Try to get through that animation here. So okay. Is that all the animation? Yes. That the patients who received the combination of ezetimibe versus simvastatin did better than the patients who were receiving placebo. So what does that tell us? It tells us 2 things. It tells me that these patients should be treated for lowering cholesterol. It tells me over this long study that ezetimibe is certainly safe. Doesn't tell me whether it was the combination of the drugs or just lowering LDL. That's sort of the controversy out there. But there's ongoing data out there to say that these drugs and certainly treating these patients are safe. Next slide. So this shows you that it doesn't matter how you slice it or dice it, being on the drug combination of ezetimibe versus simvastatin was better for these patients. Next slide. That's a lot of animation here, yeah, okay. And that's true regardless of what type of event it was. Next slide. So let me summarize, if I can, because I've gone through a lot of different aspects about residual risk. If I can summarize, I'd like to share with you that we have shown now that niacin is not proven despite raising HDL. There are ongoing trials with CETP inhibitors. And these new compounds that affect the platelets, such as thrombin receptor antagonists, we're going to have data on that. And it's going to be more confusing for all of us at the end of the day if trials are positive. But at least we'll have some drugs for our patients. Inflammation may be important, but we don't know how yet how to block it. It still has to be proven. And lowering LDL, as I started to show you initially with statins, is important. In fact, there's a lot of data out there that we're not being as aggressive as we should be. And if that's a clinical pearl, we should all go home and audit our practices to say, are we being as aggressive as we should be in patients who are truly high risk? Adding ezetimibe is reasonable in certain populations. There is ongoing and increasing data, which I've shown you today, and I do use it in certain patients. Next slide. So I'm going to end with some final thoughts and open this up for questions. Next slide. We talk about all this residual risk, but I'll remind you that most vascular events aren't sudden. They take many years of preparation. And lifestyle is so important in both primary and secondary care to reduce risk for our patients. Next slide. In fact, I think we need to think about changing our priorities. Even I've shown you some really interesting data, and we focused in our Canadian guidelines about being aggressive. Next slide. I would argue that you have a patient who's still smoking. The difference between an LDL of 3 and an LDL of 2.5 is the same as shuffling deck chairs on the Titanic. We need to address the tremendously important aspects of risk and then fine-tune the residual risk. Because there are patients, such as Mrs. W, who I showed you, who is not a smoker, who's doing everything right and is still having events. With that, I will end. I think that's our last slide. Next slide. Oh, no, one more thing. Sorry. That we have to look at lifestyle. And I can pass this on. You can email. I can take this slide and in black and white go over to my patients who come in with hypertension, right? We didn't talk. The other case we talked about, exercising, weight loss, making sure you're not drinking too much alcohol. All really important in reducing risk. Not necessarily residual risk, but often residual risk in our patients who have disease because we get focused on the high-tech stuff. We need to go back to basics. Next slide. Exercise. Hopefully you don't walk the dog in the car, and you don't take the escalators up to the fitness center. Important. Incorporate activity. I mean, I'm fortunate. I'm on the health promotion and policy committee for the Heart and Stroke Foundation of Canada. We lobby the government to eliminate trans fats. We try and create policy. We've gotten a little more in policy in the last few years. And let me tell you that it's not just exercise; it's activity, because activity is incorporating into your everyday life. Right? Walking up and down the stairs at the hospital or in your office, taking the TTC and getting off a few stops on the way home from work so we're more active, getting up and standing a bit more. I'll let you stand in a minute, but that's very important. With that, I will end. Next slide. And take any questions you have. I'm always happy to address.